My name is Dina Goname. I do telepsychiatry at the Manhattan VA. I see patients in rural settings, in the Catskill Mountains and the Adirondack Mountains, who have very few psychiatric services, and they really do appreciate that service. And I guess I just wanted to say the VA has been doing it for a long time. So they have some good data about the effectiveness of telepsychiatry. So that's good. All right, so basically my talk today is kind of a difficult talk to give because it's a rapidly evolving field. The regulations change a lot. It's different from state to state. And then this coronavirus situation has also just changed everything very quickly as well. The regulations have very much changed over the last 2 weeks to a month. So we'll go over some of those changes. I've tried to be as up to date as possible, but it's hard. So this, I wanted to discuss what telehealth was. It's a broad definition. It's a collection of means or methods for enhancing healthcare, public health, and health education delivery. And it's using a wide variety of telecommunication technologies. So it can include several things. I'm going to show you in the next slide. Okay, so one of the things, like probably the most common things we think of when we think of telehealth is the live video format, which is what most people think of. It's where it's synchronous, like there's a two-way video with the provider on one end and the patient on the other, or the caregiver on the other end. So it's supposed to take the place of like an in-person visit. That's the most common type of telehealth that I think people are aware of. There's also this mobile health, which is telepsych or telemedicine that's done through mobile devices. So mobile devices can be used to send like targeted text messages to patients, or it can send like alerts for outbreaks, for example. Another type of telehealth is remote patient monitoring. So this is a digital technology that collects health data in real time and transmits it to the provider or another location. So that would be like vital signs, blood sugars, weights, things like that. And then another type of telehealth is the store and forward technology. So this is asynchronous, so it means it is happening on one end at a different time than it is happening on the other end. So for example, let's say a nurse in one end will take a picture of like a skin lesion and then send it through a secure message or secure email to the provider who will look at it at a different time. Or they could send like videos of their gait and then the provider would look at it at a different time. That's called store and forward technology. So that's a different type of telehealth. All right, slide. And if anyone has questions, feel free to ask. All right, so telemedicine. This is the New York State definition. It's very specific. In New York State, telemedicine is the two-way synchronous live video format with the patient or caregiver on one end and the provider on the other end. That's the definition of telemedicine in New York State. Okay, next slide. So this is a typical setup for telemedicine or telepsych, which probably most people have something like this. Well, they'll have like two monitors if you're lucky, one to see the patient in and one to look at the chart, ideally. And yeah, this is like what my setup looks like. Okay, next slide. Okay. So let's talk a little bit about some of the history of telemedicine or telepsychiatry. The first case that I'm aware of telepsychiatry happening was in 1959. So the Nebraska Psychiatric Institute used early video conferencing to provide group therapy, long-term therapy, CL psychiatry, and medical student training in a Nebraska state hospital. Another early example is in 1969, Massachusetts General Hospital provided psychiatric consultations at the Logan International Airport Health Clinic using telemedicine. By the 1990s, it had spread through many areas of the world, particularly in Australia. Australia did a lot of work and research in it, and they did research on its ability to facilitate access to care and overcome geographic obstacles. And they also did research on how it compared to in-person care. And by the 2000s, there was like enough data in the field to begin to see telemedicine and telepsych as effective, but slightly different than in-person care. And there was enough research and outcomes to start publishing practice guidelines. So it was around the early 2000s when the American Telemedicine Association was created, and they started publishing guidelines. So next slide. All right, so this next slide is about the benefits of telemedicine and telepsych in clinical care. So one of the main benefits is its convenience. So it can be very convenient. The provider can be in their home, the patient can be in their home. They don't have to travel too much. It's the same thing with access. It's if the patient has like an internet connection and the provider has an internet connection, and they have a webcam, then they will have access to this. The outcomes are really equivalent to in-person care in the evidence and studies that's out there. So it's been shown to be as accurate. Treatment outcomes are shown to be just as good in many cases, just as effective, and patient satisfaction is just as good as in-person care in most cases. Another benefit or another good thing about telemedicine is that the patient privacy and confidentiality issues are usually not a big concern, or they're actually like pretty good when you look at how people view it. It parallels in-person care, so it's not inferior to in-person care in regards to privacy. And then telepsychiatry can really effectively leverage specialty expertise or telemedicine in general. So if someone is in a remote location or a rural location and they don't have access to a specialist, telemedicine can be a really effective way of getting that access. All right, so next slide. All right, so telemedicine and telepsychiatry can have a lot of benefits to specific populations. So some of the populations that can really benefit from this are like geriatric and debilitated patients. So obviously they have trouble with mobility, so this makes it much easier to reach these patients. Patients in rural populations, like the patients I see in the Adirondack Mountains. Patients with autism seem to really benefit from telepsychiatry and telemedicine. They seem to be more comfortable with a screen and the technological barrier in between them and a provider. And it's the same thing with severe anxiety. Like obviously, like patients with severe anxiety may have difficulty leaving the house so that they can see a provider. Yeah, and it can also, like patients with social anxiety, it can be easier for them to interact with someone through a screen. Okay, next. There are some potential disadvantages to telemedicine in clinical care. So some things are lost when you do an appointment through telemedicine. For example, you won't be able to smell the patient. And that sometimes provides some clinical clues. So for example, if someone has really bad hygiene, that's like an important clinical clue. Yeah, if someone smells like ketones or something like that, that's a clinical clue. So if you smell their breath and it smells a certain way, that can provide some information that you won't necessarily get. And then the touch and feeling aspects can be important, and especially in certain diagnoses. So like, for example, in the geriatric psychiatry clinic, we often look for rigidity. When we examine a patient, like if we're looking for EPS or we're looking for antipsychotic medication side effects. So that's something that we won't necessarily be able to, figure out if we're just doing telepsych and there isn't someone else on the other end helping us out to do the exam. And then sometimes you lose the big picture sort of when you're doing telepsych. Like, for example, if you won't necessarily see the patient walk into the room, or like unless you have like a good wide angle lens or something, you might not see their gait as well. So that's a negative as well. In special populations, there may be disadvantages. Like, for example, patients who are very psychotic, or like, especially if they're very paranoid, certain kinds of paranoia, like if they're paranoid about technology or cameras, this wouldn't be a good option for them. Very agitated patients, obviously, like unless there's someone on the other end who can calm them down, they might like hit the computer or the camera or something like that. It's not the best option for them. Patients who are at high risk for harm to themselves or others, try to screen out for those patients when I'm doing telepsych, because you have less control when, especially like if you're seeing them at home and they're not like in another clinic. You have to figure out how to get them to a hospital, or you don't have police or security around that can help you out. So that makes it harder. And then patients who would benefit from controlled substances, sometimes, well, up until very recently, you couldn't see patients who needed controlled substances through telepsych unless you saw them initially as an in-person visit. So that's recently changed, but for a long time that was the case. You had to see them in person first before you could prescribe a controlled substance. Any questions, by the way, so far? All right, next slide. Okay, so this slide is talking about evidence-based and outcomes in studies of telemedicine and telepsychiatry. So there's a substantial evidence base for telemedicine. Studies show that it is very valid and reliable, that there's a lot of satisfaction. So satisfaction in patients and providers is outstanding for the most part. The cost and time comparing telemedicine versus in-person visits is similar to slightly better. So obviously time is reduced if the patient doesn't have to travel a long way, or the provider doesn't have to travel a long way. Sometimes there are technological issues or issues setting things up, so that can take some extra time, but for the most part, it's similar to slightly better when it comes to cost and time. Telemedicine has been well studied in certain settings and been shown to work well in outpatient settings, consultations to primary care, and team-based integrated care settings. It has been less studied in other settings like jails, inpatient units, emergency rooms, and schools. Well, not to say that it wouldn't be effective in those areas, I'm sure it would be, but it's just not studied as well. And then it's been shown to have outstanding outcomes in several populations. Patients with depression, anxiety, cognitive disorders, developmental disabilities, and personality disorders all show pretty good outcomes with telemedicine and telepsychiatry. All right, next slide. Okay, so when I first started telepsychiatry, I wasn't sure if there were things I had to do differently. And for the most part, you don't have to do much differently. It's been pretty natural, I think, for me and the patients. But there are some things you have to do differently. So for example, you can't shake a patient's hand. You'll have to replace that with chit chat. You might have to allocate more time to seeing a patient, especially if there's like technology glitches, or let's say like you have to set things up for the camera and that sort of thing. Okay, so it can take a little bit longer. And in my experience, I feel like it takes less time for the most part, because the patient, like when you're done with your session, you can just say bye and like turn off the session. Whereas sometimes I feel like when you're seeing a patient face to face, like it can be hard to get the patient out of the room sometimes. So I think actually that it's faster. And then you have to be mindful of the setting and the room that you're in and the lighting in the room. So you have to make sure that it's a private area, that you have to also make sure, yeah, like the lighting is pretty good so they can see you well. You may be tempted not to dress as professionally. You should still be professional with your dress and your appearance. It can be helpful also to incorporate some public speaking and broadcasting skills. So it can be helpful, like if you enunciate well and you actually like enhance your gestures. That can be a good thing to do when you're doing telepsychiatry or telemedicine. And one tip is to look into the camera and not into the patient's eyes when you're talking to them, because if you look into the camera, it looks like you're talking to them, looking at their eyes, more so than if you actually look at their eyes in the image. What else? So, other things that you may need to do to adapt your practice. If you're seeing patients in another clinic or if you're seeing a patient in their home, you may have to teach the staff or the caregiver to check certain parameters like, I don't know, vital signs, weight, or let's say I keep coming back to the example of rigidity, like they could learn how to do that. They could tell you if there's cogwheeling or something like that, like perhaps a nurse. So you might need to incorporate that. Next slide. All right, so telemedicine does have unique legal and risk management issues that you need to think about. So for standard of care, the standard of care does not change if you see a patient in person versus through telemedicine. It's the same standard of care. Informed consent, a patient should provide informed consent for treatment by telepsychiatry or telemedicine prior to their treatment.
And this is, oh, go ahead. This is Shirley. I was just going to ask, how do you do that consent? Do you do it online or do you need to do it in person?
I know, like in my practice, someone will call the patient first and do the consent before they see me.
Okay.
You can also do it before you start. Ideally, you do it before.
Just gonna answer from our perspective real quick.
Mm-hmm.
So two things. One, that the need for written consent has now been waived. So obtaining verbal consent is all you need, and that should be documented right in the progress note. Two, we also, just like Dr. Goni was saying, obtain before all this COVID pandemic happened, we were having a staff member obtain written consent ahead of time. And we have examples of that for anybody. And the program we use, I don't know if Dr. Gonium's is the same, excuse me, has a feature enabled called teleconsent. So our consent document can be inside the program, and the patient can view the digital document and then digitally sign. Really easy. Mm-hmm. So good question.
Yeah, so yeah, someone will usually call, in my practice, someone usually call the patient first and get the consent, and then I will usually, the first time I see them, also get verbal consent. And then, I mean, ideally the patient should be provided with alternatives to telemedicine or telepsych. Sometimes that is not possible, especially like if they're in a very remote location, but ideally they should have an option not to do it. And then there's also the Bryan Height Act of 2008, which up until recently was enforced by the DEA, which I mentioned earlier, that a patient who is issued a controlled substance has to be seen for an inpatient visit initially, and then at least every 24 months. Next slide. All right. Some other things to consider with risk management. You have to think about your emergency procedures. So the first thing you should think about is the patient appropriate for telepsych? Now, right now I'm talking about telepsych, but I think this applies to telemedicine in general. So are they appropriate for the setting? So like I said, I try to screen out patients who would be very agitated or a risk of harm to themselves or others, because it's harder to get them care when they're like in their home or something like that, and you have to get police involved. But if you are seeing them in the home, you should be You should have like where they are located, the local police phone numbers, available local hospital information. You should always get an emergency contact before you start seeing the patient. And yeah, and like if you're seeing them in another location, like in another clinic, you should be familiar with the available staff at the facility so that you can get them if you need to. And you should also think about what to do in the event of a technology failure, which unfortunately happens quite often, actually. So, you know, you need to have some sort of policy for that. So sometimes you might think about having backup hardware or software, or maybe doing telephone backup, or if everything fails or just rescheduling. So you just need to think that through. Next slide. All right, other legal and risk management things to consider. So for your malpractice insurance, some malpractice insurances cover telepsychiatry in their standard coverage. Others require supplemental coverage. So just bottom line, you have to make sure that it's covered, telemedicine is covered with your insurance. And then state licensing is something to consider as well. So the thing to remember is that you need a medical license for the state where the patient is located. So if you are in New York and your patient's in Florida, you have to have a medical license for Florida to see the patient if they're located in Florida through telemedicine. So, I mean, that's something that like there's evolving regulations about, and people are trying to change those laws so people can more easily see patients across state lines. But for now, for the most part, you have to have a license in the state you're seeing the patient. All right, the other thing to think about is HIPAA compliance. And the platform that you're using, the app, the software, has to be HIPAA compliant, again, up until recently. So you can't just use like Skype or FaceTime or something like that unless it is HIPAA, like Skype for Business would be okay because it's HIPAA compliant, but just regular Skype or FaceTime would not be okay. And you do have to think about that because, you know, something like Skype or FaceTime, they can store your, you know, interaction. They can also limit data or limit the volume that you're of calls or something like that. And they can change their policies anytime without informing you. So it's pretty important that you choose a platform that is meant for telemedicine or telepsych.
What are you using at Downstate?
We're using doxy.me, doxy.me, and the whole hospital is actually going on to Doxy right now.
And we had talked about having students engaged in the telehealth, telepsych sessions. Is it possible to have them join in so there's more of a group?
Yes, absolutely. We did a trial of this. Carlene was there, Dr. Cohen and Clivia last week, and it went very well. We can add up to a total of 10 people to each session. I don't think we should add 10 people.
No. No.
A little voyeuristic at that point.
All right.
So yeah, so I think I'm working with the College of Medicine to move the currently on hiatus clinicals back into effect using telemedicine. And hopefully the nursing folks will join us too. I'm giving my staff this week time to adjust to their new remote working lifestyle. And we'll try to boot this up next week.
Okay, great. Thank you.
I don't think that the software we use at the VA has its own, they use their own software I don't think you can add multiple people to it, but I never asked, so good question. All right, so next slide. Okay, so the other thing to think about with telepsychiatry, telemedicine is reimbursement. This has been a barrier to more widespread use. and the state laws really vary a great deal in regards to the whether you can reimburse or how much you can reimburse. And there is a difference between coverage parity and payment parity. So coverage parity is the state will cover telemedicine or telepsych, but payment parity means they will cover it, and they will cover it at the same rate that reimbursement rate that you would have for an in-person visit. And that's not true for a lot of states. Like, for example, for private insurance, and Medicaid, there's only a handful of states that have payment parity. Most states have coverage parity, where like they cover it to some extent, but there's only a handful that cover it to the same extent as an in-person visit. All right. So.
Another question: does Medicare have payment parity?
Well, the deal with Medicare is that I think like it has to be, I don't know if it's payment, the payment is exactly the same actually, I'm not sure, but there's more regulations in terms of it has to be in a rural environment, or there are some exceptions to that, but for the most part, it has to be an area that has need for it to be reimbursed by Medicaid. Michael, do you know if that's changed much, or if the payment is similar?
Right now, all the restrictions have been lifted.
Yeah.
Okay.
Right now, we're being paid at normal visit rate for Medicare visits, whether they're happening at home or in a clinic or otherwise via telemedicine. The overall regulatory environment, probably once this is all over and it goes back to normal, right now, the only exceptions, so just as Dr. Goni was saying, you can see patients and bill for it in rural environments, or as a provider in an urban environment when you're seeing, again, patients in a rural environment, with some exception for now Medicare Advantage plans. Medicare Advantage plans are allowing more wide use, legally allowed to allow wider use of telemedicine, both in urban settings and in home settings. And it's up to the particular Medicare Advantage plan whether they're doing anything with that or not.
Yeah, it's kind of confusing because like there's different plans do different things.
It's terrible.
All right. And the other, like Medicaid, for example, for the most part, up until recently, again, like for the most part, you can't see patients in their homes. You can see them if they're in a spoke site, like another site, like they have to be in a clinic, basically, up until recently. So let's see. Okay, next slide. All right, so this is like a map that shows the states with limited telemedicine reimbursement. So most states cover telemedicine to a certain extent. You can see on this slide that some of the states only will cover video format telemedicine, the blue states. Some states have Medicaid parity. Some states have private insurance parity. Like it differs from state to state. New York was the 22nd state to pass telehealth reimbursement parity legislation, which requires commercial insurers and the Medicaid program to provide reimbursement for telehealth. But again, this doesn't necessarily mean, like coverage parity does not necessarily mean payment parity. All right, so next slide. All right, so I thought I'd do a slide on like specific benefits and special considerations of telepsychiatry in the geriatric population. So some things to think about when you're doing geriatric telepsychiatry is you may require greater staff assistance on the other end, or the assistance of a caregiver, especially in patients who have visual impairment, hearing impairment, who are agitated, who have aphasia. You're gonna need more, they need more assistance, potentially. camera control at the far end can sometimes be important, especially like if you want to see the way the patient is walking, you need like a more wide angle, and sometimes you'll need close up if you want to see like a tremor or something like that. You need to zoom in. The outcomes in telepsychiatry have been very similar to in-person care. So in assessment and cognitive interventions and outcomes, the studies show that it's very similar to inpatient care. Telepsychiatry has a lot of potential in the nursing home and in like home outreach. So a lot of patients suffer with access to care and mobility issues. So this is a very efficient way to deliver specialty expertise to them. Next slide. And then I also made a slide about geriatric telemedicine. So the studies have shown that telemedicine is actually, in many cases, superior for some reason, I don't know why, superior to in-person care in the treatment of chronic illness. So it has been shown to reduce emergency visits, hospitalizations, complications in many chronic illnesses like diabetes, hypertension, congestive heart failure, rehabilitation after stroke. So they're all good reasons to use this technology. Geriatric telemedicine has a lot of potential in the home care environment. So you could use monitoring devices to assess things like general activity level, sleep, falls, vital signs, and this information can be transmitted to the provider, and the physician's office, for example, can schedule an appointment when these parameters seem off or there's something that isn't right in the monitoring device, like the algorithm of the monitoring device. So also telemedicine interventions in home health can be provided around the clock. It doesn't have to be during office hours, or it can be when something happens. Also, the telemedicine can be used by nurses to transfer images for providers to look at, like skin lesions. And if telemedicine is done in a patient's home, it can reduce caregiver burden and the sense of isolation of the patient and the caregiver. There's also a lot of potential for geriatric telemedicine use in nursing homes and adult living facilities. Telemedicine has been shown to significantly reduce emergency room visits in these settings. Next slide. All right, I thought I would attempt to do a slide about the policy updates that have happened in the last few weeks due to the COVID-19 pandemic. So several changes have happened. Basically, most of the regulations have just been lifted or removed. So the Center for Medicaid and Medicare Services has waived the original site restrictions. So like, I was saying Medicaid, the regulation was you had to see them in a clinic setting or some sort of spoke site. But now they have waived that and patients can be seen in their own home. And so that is one thing that has been changed. There's also the Department of Health and Human Services Office for Civil Rights has decided not to enforce certain HIPAA regulations. So you can now see patients using things like Skype and FaceTime that do not have HIPAA, regulations. You can see patients any way you want, really. The DEA has also lifted the Ryan-Haidt Act regulation, so you can now prescribe controlled substances without an in-person evaluation. And then a lot of the regulations around clinician licensure during emergencies has also been changed. So when a state declares like a state emergency, it has authority to waive or modify the medical licensure requirements. So 9 states have already done this. So like patients in those states can be seen by telehealth providers in different states without them having the license that's specific to that state. So it's going to be interesting to see what happens, like hopefully when this is all over, whether some of these restrictions will, some of these like restrictions are still maintained, or you know, if they return or if these things will still be lifted, you know, if this is going to be a permanent change or not. So that'll be an interesting thing to see going forward. And that's like most of the information that I thought that I would provide to you all. But like, if you all have questions about this, there's a bunch of really good resources online. There's the American Telemedicine Association. They're the ones who create a lot of the guidelines for telemedicine. The Center for Connected Health Policy and the American Psychiatric Association also has a toolkit for telepsychiatry.
I have a question for you. This was really great. What a nice overview. My question is whether or not there's been any research about provider satisfaction with this particular approach.
Yeah, there has been. So they looked at patient satisfaction and provider satisfaction, and in most cases, the satisfaction is just as good as in-person care.
Right.
So,
okay.
Pretty good.
Thank you. This was really great. I knew a little bit about it, but what a wonderful, nice, succinct overview, and yeah, you covered all the important pieces. So it'll be great for students.
Perfect.
And providers.
Thank you. Does anyone have any questions?
I think Dr. Taylor has her hand up. Oh, yeah, sorry.
Hey, this was a lovely presentation. I have 2 questions. All right, can we get your slides or?
Sure, I can send them to you.
They were very, very nice. You're at the New York State Psychiatric?
I'm at the New York, the Manhattan VA.
Got it. Okay.
Mm-hmm.
Super. So, you know, I'm just wondering, you know, a lot of changes have happened in the last week. I'm wondering if you have heard of, so to my knowledge, NYU is kind of the only institution that is really like set up to kind of do virtual triage, to be able to have patients call in and to kind of assess, and this is mostly around sort of assessing the severity of symptoms with COVID-19. But I'm just wondering if within the broader psychiatric community, if there's something sort of being discussed. I mean, my question is really, now that mental health professionals can basically do it on their own without sort of being constrained by having the proper platform and et cetera, what about those individuals who have not been linked to care, who are having serious mental health issues as a result of being isolated, and so forth? And I'm just, you know, this is not necessarily about the content of your discussion, but you are engaged within this sort of community, providing this resource virtually, that have there been conversations in terms of sort of a hub being created where people can go and, regardless if they're linked to a particular provider, be able to check in with a licensed professional?
Yeah.
And I see this need like twofold. I see it like in terms of a virtual triage so that we can keep our emergency rooms clear of people freaking out because they have the sniffles. And second, you know, there's so many people that I think the real health issue going on is the mental health component, and to make mental health a little bit more accessible. And so I'm just wondering, you know, this pandemic is bringing out highlighting a lot of people's vulnerabilities and highlighting sort of what our healthcare system is not doing. And I wonder if sort of to address this issue, we're able to create pathways to be able to expand care, whether through getting telemedicine into people's houses, which should have been, you know, insurance companies are dragging their feet, and so now they realize this is the way to go. But
we might see, you're right,
mental health more accessible.
You're right. We might see that, like, a lot more use of telepsych given that these restrictions have been lifted. And that like I know, like, I think you've all received emails that, you know, Governor Cuomo and the New York Psychiatric Association have been looking for people to volunteer to provide, you know, provide psychiatric or mental health care for people who are isolated, who have lost their jobs, who are, you know, are dealing with illness.
Is there a website set up for that? Like, can we promote this? Like,
I know I got an email about it. I think
do you get it to Michael? You have it?
Have you gotten it?
This went out this weekend.
Yeah, it went out this weekend.
And so there's like a definitive like call number or website for us to start promoting?
I think they're just looking for people right now.
Rolling right now, that's right.
Yeah.
And I would imagine this has to be like licensed folks. It can't be folks who've done other types of counseling, right?
I mean, I think they have to be licensed, but they're not looking specifically for a psychiatrist. I don't believe they're looking for all kinds of mental health professionals.
Yeah.
Yeah, so I think it's something that is being, you know, very much, you know, like it's a need, it's a true need, and people are recognizing that. And I do think it will, you know, the access to care is going to be addressed, you know, better with these restrictions being removed. I know, like, there's a lot of patients that I see at the VA who I would never have seen. Like, they would never have entered the system if they weren't seen through telepsych, because they just don't trust the VA. They just don't trust the system or something like that. So they're more willing to do it from their home. They don't want to go into any government facility, stuff like that. Like, I definitely am accessing people I don't think I would have otherwise accessed.